the nose, paranasal sinus and nasopharynx, it forms a common unit for examination purpose. I described the anatomy of nose and paranasal sinus in previous classes, and today's class I will discuss the nasopharynx. Okay. Anatomy of nasopharynx. Nasopharynx. And I will discuss nasopharynx under the headings of extension, epithelium covering the nasopharynx, the communications, the boundaries, then the sinus of morgagni, Passavant ridge, and also I will discuss about the adenoids. Okay. So what is this nasopharynx? Nasopharynx is actually a part of pharynx. So the next question will be, what is this pharynx? The word meaning of pharynx is tube, and actually it is pharynx is a tube of around 12 to 14 centimeters in length, extending from base of skull up to the lower border of cricoid cartilage, or that corresponds to around this C6 vertebra. Okay, so you can palpate the cricoid in your own neck. The one which is moving with deglutition is the thyroid cartilage, and below that you will get a change in consistency. So cricoid is a complete ring, and there is a change, consistency is changing from the thyroid cartilage to cricoid cartilage. So the pharynx extends from the skull base up to the lower border of cricoid, and actually the pharynx is a crossroad for air and food passages. Okay, you can take this pharynx like this. It is actually a crossroad, and from this pharynx, it goes to the nasopharynx, to the nose, and from the nose, what is this? It is going from the lateral side of nose, from the nasopharynx goes is the opening of the Eustachian Tube. Then it comes into the oral cavity. Okay, towards this, there's an oral cavity. Then it goes to the larynx, that is the air passages, and to your esophagus. Through the cricopharynx, it goes to the esophagus. Okay, this one going to the esophagus, this going to the larynx, and then to the oral cavity and to the nasopharynx. Okay, and each of this crossroad is guarded. Like a security, there is guard in each of the crossroad, which is actually the muscles acting there. At the opening of each of these crossroads, either into the nose, to the oral cavity, or to the larynx, or to the esophagus, there are muscles directly acting there in the form of some sphincters. So, to the junction of nose to the nasopharynx, there acts the levator palate and also the superior constrictor. Okay, so here comes the levator palate and superior constrictor. The levator palate and superior constrictor, they are the muscles which act as the sphincters. And towards the oral cavity, it is the palatoglossus and the intrinsic muscles of the tongue. Okay, tongue muscles towards this. And what is at the opening of esophagus? There comes the cricopharyngeus muscle, and the larynx is closed by the action of oblique fibers of interadenoid and airy epiglottis. Okay, and here is the cricopharynges. Right, so these are the muscles which act as sphincters at this crossroads. So what are the divisions of pharynx? We divide that into nasopharynx, then the oropharynx, laryngopharynx and hypopharynx. Okay, actually these are not the true anatomical division, but this is as per the TNM system used for the staging of cancer by the UICC classification. Okay, that is based upon the UICC. Today's class is on nasopharynx, so we will concentrate on this area. Right? Extension, it extends from the skull base up to the soft palate. And epithelium, actually it is a continuation of the nasal cavity. So what will be the epithelium? The epithelium will be respiratory epithelium, which is pseudostratified ciliated columnar epithelium, right? And what are the communications? That is very evident from here into the nasal cavity, or it can go through this Eustachian tube. It will go to the middle ear, okay, and also into the oropharynx. This is the oropharynx. Okay, so three communications. One into the nasal cavity. Second, it can go to the middle ear through the Eustachian tube, and also to the oropharynx. Okay. Then coming to the boundaries, we have actually the you can see this is the anterior wall, and there is a posterior wall which unite with the roof and the floor, and also there is a lateral wall. So what forms this anterior wall? Anterior wall is actually the posterior aperture of the nose, isn't it? Here comes the posterior aperture. Otherwise we call it as the choana. Plural, it comes as a choanae, right? And through the choana you can also see the posterior end of turbinates and meatus, right? And the roof and the posterior wall, here comes the roof and the posterior wall, actually they merge together. And the roof is formed by, this is a sphenoid sinus, so this is a basi-sphenoid and basi-occiput. And posteriorly, the arch of atlas communicate with the dens of axis, and it is covered by the prevertebral muscles and fascia. Okay. So the roof is formed by the basi-sphenoid and basi-occiput, and which merges with the posterior wall, which is formed by the atlas and axis vertebra with the prevertebral muscles and fascia. And on the floor, what is on the floor? It communicates. Anteriorly there is a soft palate. Posteriorly it communicates with the oropharynx. Okay, through the nasopharyngeal isthmus. There is a nasopharyngeal isthmus that I will tell you what it is. And it communicates with the oropharynx. And on the lateral wall, on both sides, there are also some structures contained in the roof and the posterior wall. One, what is this? That is the adenoids, right? Adenoids. Adenoids actually they have got vertical grooves, and there is difference in morphology from tonsil. Tonsils are actually like this. They have got medial surface is made into so many folds, and adenoids there is vertical furrows. One, there is a nasopharyngeal bursa. Nasopharyngeal bursa. What is that? This pharyngeal bursa represents the embryonic site of attachment of the notochord to the pharyngeal endoderm. Okay, and it is seen within the adenoid mass. It is seen as an epithelium-lined recess within the adenoid mass, and it extends from this pharyngeal mucosa up to the periosteum of the basi-occiput. Okay, from the pharyngeal mucosa, it extends up to the periosteum of the basi-occiput, and it is seen within the adenoid mass, and it represents the site of attachment of the notochord to the pharyngeal endoderm. That is the nasopharyngeal bursa. And the third thing is a Rathke's pouch. And what is this Rathke's pouch? Rathke's pouch is seen as a dimple above the adenoid, where this posterior end of septum comes and joins with the roof of nasopharynx. It comes exactly here. The posterior end of septum comes and joins with the roof of nasopharynx. Just posterior to that, above the adenoids, you can see the dimple, which is the Rathke's pouch, a remnant of the buccal mucosal invagination, which forms the anterior lobe of this pituitary. Okay, that is Rathke's pouch. So in the inside, attached to the roof and posterior wall, you can see these structures. lateral wall from anterior to posterior. First you can see the Eustachian, pharyngeal opening of the Eustachian tube. Then behind that is a tubal elevation called torus tubaris. And behind the elevation there is a potential space which is called the fossa of Rosenmuller, which is the commonest site of origin of nasopharyngeal carcinoma. And also there is a tubal tonsil which forms part of Walde's ring along with adenoid and the palatine tonsil, and also there is a salpingopharyngeal fold. Now you are going to see the nasopharynx through choana, and the lateral wall of nasopharynx contains the pharyngeal opening of the Eustachian tube. Now the pointer is on the pharyngeal opening of the Eustachian tube, which is situated 1.25 cm behind the posterior end of inferior turbinate. Then behind that is the elevation you can see, which is a torus tubaris. There is an elevation raised by the cartilage of the Eustachian tube, and it bounds the Eustachian tube above and behind. And going behind the torus tubaris comes the fossa of Rosenmuller, which is a recess situated above and behind the tubal elevation. There is also collection of subepithelial lymphoid tissue continuous with adenoid tissue and forms part of the Walde's ring called the tubal tonsil. And now the cell seeker is on the towards the roof, that is where the adenoids are situated. Actually, see the soft palate at the lower part, and after boundaries, what is this sinus of morgagni? It is usually asked as short note also. Sinus of morgagni is actually this space. That is the space between the skull base and the superior constrictor. So before going to the sinus of morgagni, I have to tell you the pharyngeal wall of pharynx. Actually, this is the pharyngeal wall in a coronal section. There are actually 4 layers starting from the mucosa up to the buccopharyngeal fascia. And what the inside out. So the innermost is the mucosal layer, which in the nasopharynx it is a stratified ciliata columnar, which is a respiratory type, and in all other part it is stratified squamous epithelium. Okay, so that is the mucosa, and in the nasopharynx it is a respiratory type. Next is the pharyngeal aponeurosis, which forms the pharyngobasilar fascia. Okay, and then comes the muscle coat. After the pharyngobasilar fascia comes the muscle coat. Actually, this is the outer coat. There are 2 layers of muscle coat, and outer horizontal circular muscles. They are the horizontal fibers, horizontal muscle, and there is an inner layer of vertical muscles. Right? There are 2 layers. This is the outer layer which forms the horizontal fiber, that is the superior constrictor, middle constrictor, and the internal constrictor. And what forms the vertical inner layer? That is by the stylopharyngeus muscle. 3 pharynges. They are the stylopharyngeus, salpingopharyngeus, and palatopharyngeus. They are actually vertical group. Internal, inner, vertical group. 3 pharynges. And the superior constrictor, middle constrictor, and the internal constrictor on the inferior, then the superior constrictor, middle, and the inferior constrictor muscles forms the outer vertical group. And after that you have the buccopharyngeal fascia, which forms the outermost layer. So the layers of pharynx are from inner to outward. It is the mucosa, pharyngobasilar fascia, then comes the muscle layer, and then comes the buccopharyngeal fascia. And this buccopharyngeal fascia unite with the pharyngeal aponeurosis at the upper border of superior constrictor. So there is a gap between the skull base and the superior constrictor, and that is called the sinus of morgagni. Okay, so what are the structures passing through the sinus of morgagni? It is important, it can be asked in MCQs also. One is definitely it is a Eustachian tube. Actually it comes here, isn't it? So other than Eustachian tube, you have the palate here. So there are two structures. Altogether there are 3 structures passing through the sinus of morgagni. One is a Eustachian tube, another one is an artery, and another one is a muscle. So the cartilaginous part of Eustachian tube. Along with the palate is here, so it is a levator palate. Okay, so it is a levator palate muscle, and third is a ascending palatine artery, which is a branch of facial artery. Okay, what is the importance of this sinus of morgagni? Importance is that it forms a pathway for the spread of nasopharyngeal carcinoma from the nasopharynx to the lateral skull base. Okay, so that is the importance of this sinus of morgagni. And what is in connection with that, you have also to remember, that is the Trotter's syndrome. And what is this Trotter's syndrome? Trotter's syndrome is an symptom complex seen in advanced nasopharyngeal carcinoma. So what all things can happen? This nasopharyngeal carcinoma can go through the Eustachian tube. It can go to the middle ear. So if it is going to the middle ear, there can be middle ear effusion. So there will be what? There will be conductive hearing loss, isn't it? There will be conductive hearing loss. Then second, what can happen? This is filling this area, isn't it? So the second, levator palate involvement. So there will be soft palate immobility. Okay, immobile, soft palate. So if it is involved in the Eustachian tube, it can go and cause a conductive hearing loss. If it is involved in the levator palate, it can cause an immobility of the soft palate, and it won't cause ascending palatine artery involvement, cause not of much symptom. But if there is a perineural spread, it will go for trigeminal neuralgia. Okay, fifth now, trigeminal neuralgia. So these are the components of this Trotter syndrome, and this sinus of morgagni forms a route of spread for the nasopharyngeal carcinoma to the lateral skull base. And the structures passing through them are Eustachian tube, levator palate, and the ascending palate. This is the view, coronal cut from nasopharynx, oropharynx, and your laryngopharynx. So this is the posterior end of septum and the choana seen posteriorly. So there is a muscle called Palatopharyngeus muscle, which originates from the posterior border of the hard palate, and then it goes laterally to the pharynx. Okay, lateral pharyngeal wall. And this is the palatopharyngeus muscle. And this palatopharyngeus muscle, actually this palatopharyngeus muscle forms a mucosal ridge on the lateral as well as on the posterior surface, posterior wall of the nasopharynx. So, during swallowing or speech, this soft palate as well as the uvula will go posteriorly and laterally, and it makes a firm contact with this Passavant ridge. That is how we have a correct twang to the voice, and also it prevents it from nasal regurgitation during swallowing. And the derangement of the system can happen if there is a cleft palate, or there is an hypertrophied adenoid, and also after adenoid surgeries. Especially after adenoid surgery, you must have noticed open voice to the patient. So that is because of this derangement in this approximation with the Passavant ridge, or otherwise it is a velopharyngeal insufficiency. Okay, so that is the importance of this Passavant ridge. Then comes the adenoids. So what about the adenoids? Location, you know, it is located at the roof, junction of roof and the posterior wall of nasopharynx. They normally they will grow up to 6 years of age, reaches a maximum size by around 5 to 6 years. Then it starts regressing, and by the age of 20 years, 18 to 20 years, it completely disappears. If there is allergy or due to any other cause, if there is an hypertrophy of the adenoid, it will lead to so many discomfort like adenoid facies, or there is recurrent secretory otitis media and the like. And it is situated almost here, And the usual question asked is the difference between an adenoid and the palatine tonsil. Okay, so how can you make the differentiation? Adenoid, tonsil. The first one is the location or the site. Where is the site? It is the nasopharynx, and the tonsil, it is the oropharynx. Okay. And the number, what about the number? There is single adenoid, and here there are two tonsils, right? And actually these adenoids are like this. There is only furrows. There is vertical furrows for the adenoid, but for the tonsil, it is like this. There are crypts, tonsils. Okay, the medial surface, there are crypts present. So, crypts bar furrows. Here it is only furrow, and here comes the crypts. And another thing, a capsule is present in case of tonsil, and there is no capsule for an adenoid. And what about the epithelium? I already told, along with the epithelium, it is ciliator columnar. Okay. For the adenoid, it is ciliator columnar, and for here it is stratified squamous epithelium. Actually, the mucosa is ciliator columnar only in the nasopharynx. In all other part of pharynx, it is stratified squamous epithelium. It disappears in adult. Okay, which one? Adenoid. Usually it disappears about 20 years of age. But tonsil is present even after 20 years of age. So these are the main difference between this, and all these two, both tonsil and adenoid, forms part of the Walde's ring also. Okay, examination, along with the examination of nose, paranasal, sinus and nasopharynx, one thing you have to check is postnasal examination. Actually, in clinical practice, because of the development and the invention of this diagnostic nasal endoscopy, it is actually this postnasal examination is almost obsolete. Nobody does it nowadays. But for examination, you will be asked, especially the postgraduate will be asked to tell how you will do in postnasal examination. So actually this is a postnasal mirror. This one, the difference from an indirect laryngoscopic mirror is a curve in this. Okay, this is a postnasal mirror. And how will you do a postnasal examination? So the patient is sitting in front of you, and first, so seat the patient in front of the examiner, then explain the procedure to the patient. That's the second thing you have to do. And the third, take the postnasal mirror of adequate size. There are sizes ranging from 0 to 4. 4 or 5 will be there. Number 0 to 5, up to 5. So depending upon the size of the oral cavity, take it. For children and young adult, the 0 or 1 will be adequate. And for adult, 2 to 3 will be sufficient. And if you put the postnasal mirror like this, usually when the patient breathes, there will be fogging will happen and you will not be able to see anything. So for this, first you have to do some either dependent anti-fog solution, or if there is no anti-fog solution, you have to heat it over a spirit lamp. So the thing you have to tell is preheat the mirror and temperature testing. So the procedure is seat the patient in front of the examiner, explain the procedure to the patient, preheated and temperature tested mirror, postnasal mirror of adequate size, and ask the patient to open the mouth with the tongue inside. Just open the mouth, and with the lax tongue depressor, you depress the anterior 2/3 of tongue. Okay, just depress the anterior 2/3 of tongue, and then you insert the postnasal mirror, go behind the uvula, and ask the patient to breathe through nose. That is important. If the patient is not breathing through the nose, breathing through mouth, what will happen? This palate, soft palate will go posteriorly. Okay, so there won't be adequate space. So after depressing the tongue in the anterior 2/3 of tongue, insert this, go behind the uvula and ask the patient to breathe through nose. Okay, then you can see. This is how you will see in a postnasal examination. Right? So what all things you will see? You will see the posterior end of septum, you will see the posterior end of inferior turbinate, the middle turbinate, and on tilting the mirror sideways, you will see the Eustachian tube opening also. Okay, then the uvula on opening the mouth. So this is how we have to draw a postnasal examination, right? And if there is some mass, it will be, you have to mention it in the picture also. Next is the nerve supply. What is the nerve supply? You have both motor and sensory. Sensory supply, we can divide it into part anterior to the, what is the important structure in the lateral wall? It is a Eustachian tubal opening. Okay, so anterior to Eustachian tubal opening and posterior to Eustachian tube opening. Anterior to the Eustachian tube opening, you have the trigeminal through V2, and posterior to the Eustachian tube opening, the sensory supply is by glossopharyngeal. Okay, and regarding the motor supply is by 9, 10, and also you have the sympathetic plexus from superior cervical ganglion. Okay. This is regarding the nerve supply. Arterial supply is mainly to three artery. They are the ascending pharyngeal, the spinopalatine, and artery to pterygoid canal. And the venous drainage is mainly into the pterygoid venous plexus. From there it goes to the internal jugular vein. Right? The lymphatic drainage of the nasopharynx is very important because it plays a major role in the spread of tumors, especially the nasopharyngeal carcinoma. So actually there is a rich network of capillary lymphatics in the mucosal layer. From there, from the posterior side, it will go to the, from the posterior wall, it will go to node of Rouvier. Which is, what is this node of Rouvier? It is a retropharyngeal lymph node. Actually there are median group and the lateral group, and the medial group it atrophies by age, and the lateral retropharyngeal node is otherwise called the node of Rouvier. And from the lateral wall it mainly go to jugulo-digastric and also mainly the 3, 4 and 5 of cervical lymph node, and also partly to level 2 lymph node. And from there, from both sides, it will go to the deep cervical lymph node and then to the nodes along the internal jugular vein. Lymphatic drainage is also important. So regarding the nasopharynx, we told about the boundaries and the epithelium, the communications to the nose, middle ear and to the oropharynx. The boundaries mainly the roof and the posterior wall, then the lateral wall, the floor and also anteriorly, then the sinus of morgagni, the importance, Passavant's ridge and also the adenoids, and we talked about the difference between adenoids and tonsil. Okay, if you have any doubt regarding this, just put in the comment box. Thank you.